Welcome to Frame by Frame, Rethink Imaging, a podcast by Immunologics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. Welcome back to Frame by Frame, Rethink Imaging. Today, we are picking up part 2 of our conversation with Dr. Ehsan Samei. If you haven't listened to last week's episode, part 1, on why medical imaging matters, we recommend going back and taking a listen before joining us today. In today's episode, we are going to explore how we approach measuring the benefits of imaging and why those measurements are important to talk about. And we were just on a little break from our conversation, Dr. Samei, and getting not ahead of ourselves, but just, we were chatting away. And I want to jump right back into what we were talking about on the break, which is you mentioned measurands versus measurements. And can you just explain to me and our listeners the difference between those two concepts to get things started?
Thank you again for doing this. You're such a great conversationalist, and I appreciate the time that we have spent together. So measurand is an attribute worth measuring. And measuring is what we do. I'm a physicist. I'm a medical physicist. We like measuring stuff. So we measure measurands. So for example, you can think about what are the attributes of air, humidity, temperature, pressure. These are measurands. And then we can apply our measurements to measure those things.
Okay. Super simple and straightforward. I got that far. Then what are the measurands when it comes to not just imaging, but the benefits of imaging? This is where it starts to get super murky again.
When you think about the way we practice science, science is primarily a quantitative enterprise. A lot of the work that we do in science is quantitative. In the Enlightenment, we divided the reality into qualitative and quantitative. And quantitative took off. And with quantitative, we created industry, we created the science, modernity, and the approach to the universe in terms of measuring the universe, assessing the universe, improving the universe. A lot of them are numerically based. So we like to measure stuff. Why do we measure stuff? Because if you measure them, then you have a sense of control over that attribute. You can target certain things. You can track them. Like, for example, how do you know you're overweight, you're underweight? You measure yourself. You see, the weight has gone up. It gives you something to gauge yourself as opposed to how I feel today. I'm not sure which way, by the way, is better. But the point is that having a measurement at your disposal to figure out how you're managing your health is helpful. Would that scale give you everything that you need to know about your health? No. Or all the measurements that we make on your blood in terms of how much cholesterol you have and lipid, all that stuff, do they fully describe your blood chemistry? No. But it's very helpful. We can practice medicine with it. So when it comes to imaging, it's the same story. In order to be able to practice and target radiology to a certain level of quality, I need to have a measurements at my disposal to be able to target them. Do I fully characterize the benefit of imaging? No, but having some numbers would be very helpful. As long as numbers are not misleading us, right? Sometimes you can have a fake number or a number that is not really representing the reality. So any sort of measurements or measure that reflect the measurand is we try to represent numerically an attribute of that entity that is helpful and reflective to understand that entity. So
right.
Going back to your original question, can I measure the benefit directly? No. In fact, rarely can I measure anything directly, but I can indirectly measure it with a series of measurements.
Right, because in medicine, we're tracking outcomes by the success of treatments, but imaging in itself is diagnostic. So how do we connect measurable outcomes like lives saved, complications avoided, and connect it to the diagnostic tool?
Yeah, right. So you're asking the right question. First of all, in medicine, our goal is to provide health or advance health or foster health. So ultimately, quality of life, years of life and mortality are the proper measurements that we should go after. Often those things cannot be measured now, right away. Why? Because first of all, it takes a while to get those results. Now, by the time you pass from my intervention or not pass from my intervention, I'm long dead myself. So it doesn't, so often we cannot get our hands on that thing ourselves directly. Secondly, sometimes things get very compounded because I don't know, you might not because of what I did to you today, but somebody else did something to you 6 months from now. And then now I cannot really, that number that I was planning to get out of you as a patient is now contaminated. I can't get my hands on it. I cannot put you in a test tube. You are going to live your life and you're going to be affected by a variety of factors, which is different from you to me, to my wife, to my daughter. They're all over the place. So this confounding effect makes it very difficult to try to actually measure any of those things directly. So when it comes to diagnostic care, that would take a few steps back and say, okay, I can't measure that very easily. Is there something that I can measure? I would say there is one thing you can measure. You can measure radiation dose, which, in fact, that's probably the easiest thing you can measure. Which the problem with the radiation dose is that, as we talked in our previous podcast, is misleading because you only reflect one attribute, one measurand of that process. And in fact, it's not even directly to benefit at all. Right. But the other thing that images are supposed to provide, when you think about why do we do imaging? We do imaging in order to provide information from the interior of the patient. So I can come up with some measurements that reflect how well the information is reflected in the images that I'm given. So if there was something there, how truthful the image represents that reality. So information transference factor, if you will, right? Did I get that? If there was something in there, did I get it did it get captured in my image? Right? That is an indirect measure of the benefit that the images themselves supposed to provide. Now, how that benefit get propagated through the life of the patient and the treatments and other confounding effects, I cannot tell about that, but I can tell you whether images were any good in representing the content that they're supposed to produce. Am I making sense?
Yeah, absolutely. You're talking about dose, which is the most easily measured measurand, but also saying that it's an unreliable measurand. Is that correct?
Unreliable or not misleading is too monodimensional. Monodimensional means, like, imagine for a second you're trying to assess whether a food is good for you, and the only measurement at your disposal is the calorie. That's the only thing you can measure, right? You're actually a food expert yourself.
Can you expand on that a little bit?
I mean, if I tell you that essentially you can rank order restaurants across New York City based on the calories that they put out there for a given standard dish, do you think that would be a good reflection of the quality of the food that you receive at those restaurants?
Absolutely not.
Yeah. So why would that be? Would you say that calorie is irrelevant? You probably would not say calorie is irrelevant. It is a measurement. But if that's the only thing you got, there is no other measurements at your disposal. And you measure the quality of my hospital versus another hospital, my restaurant versus another restaurant, based on only that one single metric. I think you can't really mislead yourself.
No.
Imagine Michelin stars would be based on the calorie of the restaurant. That would be a joke, right? Sometimes the dose is so easy now. I feel like now we have set up a system, at least in this country or many other countries as well, that we just measure that calorie input or output, whatever you want to call it, of imaging as a metric of how good you are as a radiology department. That's a joke, if you ask me. That doesn't mean you should ignore the calorie, but you should think about, okay, can we say more? Is there other measurement? Can I measure the sourness or sweetness or bitterness or whatever? Are those things relevant?
Right. So, I mean, in terms of imaging, then, like, if we're talking about noise and image quality and these other things, like, at what point do we start to have a clearer picture? Clearer picture metaphorically, but then realized it was applying quite literally and laughing to myself about it.
It is literally, that pun is well intended. Here, I want to know if this picture is good and that picture is bad. The picture that is good is a picture that represents the reality more faithfully than the picture that is bad. Okay, so when you say faithful representation of reality, faithful representation of information, translation of information from a real domain to an image domain, right? What are the things that you consider good quality? Like, there are certain things that you know, for example, you want to have high resolution. We already know that. Like, for example, if you get a latest iPhone, it claims to have the more pixels representing that image. And more pixels, that means the pixels are actually tinier and smaller. That means the images are higher resolution. That means the spatial details are more faithfully reflected in the image. The other thing is the noise. It means apart from those spatial details, what are the fluctuations that are existing that manifest themselves primarily, by the way, when you, in the photographic imaging, when you take an image without a flash. The sharpness, the clarity is not there because of the statistical fluctuations of pixels. So resolution is one, noise is one, contrast. So if I have a black region and a white region, do they represent themselves differently? That would be yet another one. Images in imaging, patients perpetually move. We are dynamic entities. Our heart is beating, we breathe. There are internal movements within the body itself that we do not control. And when we take a snapshot, when we take a single snapshot of the patient, that motion is get solidified into the images. So all images have certain amount of motion artifacts in them. Some of them are large, some of them are small that we ignore. So motion would be another one. There are, when it comes to like CT images, there are all sorts of other artifacts like streaking artifacts that are present. There are blooming artifacts that are present that would mask reality of what is going on. So these are attributes. Do they reflect the actual quality of the images perfectly? The answer is no. No measurement reflects everything perfectly. That's my point. But approximately yes. In the same way, a food package that has calories but also saturated fat and salt and sugar and all that stuff, that label is better than the label that only has calorie. So I think what we need to do is to identify attributes, measurements that reflect that clarity that you mentioned earlier. And an image that produces higher clarity, then that image would be a better image, has a potential to provide higher benefit to the patient and to the practice.
Right. So, are there ways to measure a measurand of quality in radiology? And how do we know if the measurements are relevant or reliable?
Right. So that's a great question. I think because the science of image quality is a still developing science, I think whatever measurement that we make, Chris, needs to lend itself to scientific scrutiny. By scientific scrutiny is that in science, if I come up with an idea, you don't take my words for it. I have to prove to you that what I have is right, and I have to prove to my peers that what I have is right. So peer review is a hallmark, has been a hallmark of scientific inquiry. So a measurement needs to stand the scrutiny of a peer review, needs to be proven by others other than the person who developed it, in my opinion. And community at large needs to accept it. So it's not just for me or for you or for this company or for that university to say this is the right way of measuring noise or resolution or whatever. I think we need to communally come together and say this is the right way of measuring it. The third thing I would say is that we need to have some validation that measurement that we have come up with or the way we have done the measurement is related to that outcome that you refer to early on in this conversation. Remember that the measurement itself, if I measure noise and resolution, is not what images are all about. A radiologist don't go and measure noise in images or measure resolution. The radiologist to detect the cancer if the cancer is present. So would those measurements of mine that I just made, are they related to the likelihood of the practitioner being able to do the diagnosis that is needed? If my measurement is not related, cannot be correlated with what the physician is able to do with the images, my measurement is useless, right? So it needs to be validated to a clinical touch point. Measurements are physical stuff. They're geeky stuff, by themselves are useless. It needs to be anchored to clinical reality. So it needs to be anchored to clinical reality, needs to be scrutinized, needs to withstand the scrutiny of the peer review, and needs to be owned by the entire scientific community. That's the only way I can trust a measurement.
So how do we do that?
Well, yeah, that's again, right. How do we do that? First of all, I think anybody who comes with the measurements, I think we should see if there is evidence that there is some confidence for that. There is a peer review publication that goes with it, number one. And secondly, is that the variety of stakeholders can accept it.
Right.
So AAPM, I think a couple of years ago, put a panel together, and the result of that panel was published. It was not a panel, sorry, I'm misspeaking here. There was a stakeholders roundtable in which AAPM is stand for American Association of Physicists in Medicine. It was not the AAPM initiative. It's AAPM just invited a whole bunch of other entities, including radiological societies, non radiological societies, governmental agencies, even patient advocates around the table and say, how do we ought to measure quality of imaging? How do we measure? And we realized that we need to share that space. Physicists cannot dictate this, radiologists cannot dictate this, government cannot dictate this. It is owned by all of us together. So I think we need to have an entity that a table, a round table, which everybody has the same real estate at the table, that can together come up with a series of measurements and ways to do those measurements that is accepted by all. That way we can move together. That's the way AAPM has advocated. I totally support that idea. That the result of that roundtable was published in an article in early last year in the Journal of American College of Radiology. I highly recommend your listeners to check that out. I think that's the right strategy. And the problem is this: without that, we come up with bad measurements. Early on, one of the measurements, and it might still be in practice, one of the measurements that was instituted by some entities was in fluoroscopy imaging. You know, the fluoroscopy imaging is a form of imaging in which you get a video of the patient. It's not a single image, it's a series of images, right? And usually when the procedure becomes complicated, the length of the exposure gets longer and longer. You might image the patient for 5 minutes, 10 minutes, 20 minutes, 30 minutes. So one of the entities suggested that the length should be a measure of the quality of that practice. Shorter is the better. All things being equal, I agree. A shorter fluoroscopy examination is better than a longer one. But if you're really, really sick and I have to do an hour of examination, is that really I'm doing you justice by limiting it to 5 minutes? No, right? So the point is that, going back to one of the things that I mentioned in our previous podcast, caring for the individual patient is number one priority in any healthcare enterprise. And when you throw in a bad metric for quality and measure hospitals based on the length of their fluoroscopic examinations, undermines the actual care, good quality care for the individual patient. So bad measurements is bad for practice. So that's why it's important to make sure the measurements that we come up with are owned by the entire community.
And just to build on that, I mean, it ties back to what you were talking about, a threshold versus a guidance, right? Like, this is what you're building on. Yeah.
Owned by the community and should not be threshold based, should be guidance based. Guidance. So that means you are honoring the reality of the need for personalized care. We're not saying you need to practice medicine haphazardly, but you need to allow the agency and expertise of the practitioner and the voice of the patient to be present in the care process.
So we've talked quite a bit about personalizing the imaging process, but how does personalization apply specifically to radiation dose? Should dose also be tailored individually for each patient?
Yes, that's a good question, Chris. As I have talked in the first podcast, and also in this one, big part of what we need to focus on is a personalization itself, whether in the context of image quality or radiation dose. We need to customize our radiation dose and image quality to the individual need of the patient. So if you are dealing with something that is related to your thyroid or your liver or your brain or your heart, we need to make sure the imaging that we do specifically extracts the information needed for that specific care that you're coming to the medical facility for. We also, at the same time, need to minimize the radiation dose that you receive. Radiation is a gift to medicine, but just like any other gifts, including pharmaceuticals and so on, you need to use it responsibly. What is the right dose? How do we measure the dose for an individual? By and large, the medical community has taken this aggregate approach toward radiation dose that doesn't personalize it. So, for example, in the context of CT, we use CTDI, CT dose index, as a metric of radiation dose to the patient. But actually, that is not the metric of radiation dose or burden of radiation to the patient. It's rather is a reflection of the output of the imaging device in terms of radiation that puts into the patient. So the level of harm, hypothetical, theoretical, linear threshold oriented, however it is calculated, needs to be related to the individual Mr. X and Mrs. Y. What part of my body is exposed matters. How much radiation flux goes to different organs of my body actually matters. What is the size of my body? That matters. What is my age? Matters. If I'm younger, if I'm older, changes the calculation of risk completely differently. What is my sex? Affects my radiation burden. All of those factors are, by and large, are ignored in the measurements that we are currently using for radiation dose in medicine. So radiation dose in medicine also needs to be personalized in the same way that image quality is personalized.
Okay, I mean, let's pivot a little bit, right? We're talking about measurements, we're talking about measurements, and the challenges in measuring the quality of images or imaging. But how do we tie the results of imaging in this clinical chain of practice to the result, right? So, for instance, if you have a trauma patient and you identify like a brain bleed, or if you identify cancer in a patient through imaging, or whatever it is, you are branching out through this healthcare system into different departments, into different areas. And when you're trying to measure all of that, I feel like it starts to get incredibly convoluted incredibly quickly.
That is true. And that's one of the reasons that, at least in radiology, we try to measure, at least that's an easier task of answering the question, do images provide the information that they're supposed to provide? So there are a variety of doing that. One is that you measure things such as we talked about this resolution and noise and contrast and motion and blooming and streaking and so on. You can measure those things. Those are equivalent, using the food analogy, equivalent to sourness and sweetness and saturated fat. And so that we measure those things. And those are what in imaging language we call them task generic. They're attributes of the images in representing the ground truth that might be present in the patient. Then you can translate those numbers into what we call task-specific reality. That means now, if you happen to have a bleed in your brain, or plaque in your heart, or cancer in your liver, how confident we are that image can represent that abnormality well. That would be task-specific representation of those attributes. And by the way, that task is specific. That was established by an international body many years ago. ICRU report number 54 says, if you want to measure image quality, that's the right way of measuring image quality, by the way. So there have been a fair amount of science to translate these noise and resolution and motion and stuff into that task-based performance. If I know the resolution and noise and those attributes, I can put them into a formula, if you will, and tell you how well this image would represent brain bleed versus cancer. Then, depending on the indication for which the patient gets imaged, which is often we know that, right? Nobody go and images you because you want to get an image. Usually, that's bad practice, right? There is always an indication. There is a reason. We're suspecting of lung cancer. We're suspecting of breast cancer. We're suspecting of this or that. So there is a target in mind. If you give me the target, I can tell you that image is good for that target. Or the dose needs to be adjusted up and down to make that target more visible to the level that the level of visibility is sufficient for the physician to act for your care, right? We don't need to know everything. We need to know enough to what we need to do with you clinically, taking the next step. That is the usually guidance that is provided. So we have done, at least in my laboratory, we have done a number of studies, and at least I have done 3 studies in my lab. These studies have not been very many of them, that we have done this. We have done the translation from those basic measurements to task-specific performance, like detection of cancer. And then we have done the detection performance with actual practicing radiologists and asked the question, do my prediction of that task performance measures against the practice itself? When I say validation, that's what I'm talking about. That means now my measurement is now made relevant. I've demonstrated that what I'm measuring is actually relevant. Would be equivalent. This is almost ridiculous what I'm saying, but you get the idea. Imagine if I come up with a formula that get the label on the back of the food packaging, add it to my formula and tell you how delicious the food is. Imagine for a second. It would be task-based performance type of thing. And then do a study in which I ask a whole bunch of people to eat a whole bunch of food and measure the deliciousness, rank order deliciousness, and see how my formula matches theirs. If they match, then you believe my formula, right? That's basically like this. I would say, though, when it comes to image quality, I think our formulas are much better than using the food analogy. Food is really much more complicated.
Right.
Because, medical images at the end are scientific, technological tools. So we are a little bit more, lend themselves more to that kind of measurement, while like food, which I'm using that analogy over and over, is more of an artistic reality, right? Yeah, I cannot come up with an algorithm to tell you this, take a picture of your painting and say, okay, this worth $100 million based on my formula. That doesn't work that way.
Right. That would just be the golden ratio at that point, which would be a great little cheat code if you could just paint a painting with that ratio and then it would just sell for a bunch of money. That'd be great. Is the question, should radiology departments be doing more to document outcomes and demonstrate their role?
Yeah, I think we should do more this kind of measurements than describing. I think that needs to happen. I think we need to also measure the outcome. All of measurements that we make are insufficient, but we need to have measurements nonetheless. In fact, every form of measurement is a form of approximation, right? And I think given the fact that nowadays people are just so consumed by those or obsessed by those, I'm not sure what the right. I think we need to go out of our way to demonstrate the value, even though it's so obvious to us, how well the images represent what they're supposed to represent, and what would happen to the patient if those images are not acquired or suboptimally acquired. I think we are very fear-minded in the way we practice medicine. Again, we need to make sure we maintain utmost safety in the care of the patients. There is no question, but we should never lose sight of the fact that there is a significant amount of value and benefit to the care of individuals that imaging provides, and you never want to compromise that.
Okay, so let's play around a little bit, if that's okay. Let's say theoretically you had unlimited data and unlimited funding. How would you design a study to answer the question, how many lives does imaging save? Just real quick on the spot. Just solve this problem for us.
I think what I would do, first of all, number one, I keep track of the indication for which the images of a certain series of patients were acquired. So let's say we would get, randomly select 1,000 patients that were imaged at my facility and ask the question, what indication brought them to that scenario? That will keep track of actually what the images provided for those individuals for that scenario. What I would do is that I would ask the question from the practicing physician who cared for the individual, if that image was not available, how the course of the treatment or follow-up for the patient would have been different. And you make a predictive modeling, what would happen to that patient, not a hypothetical patient, that particular individual. I also asked the question if the images were if radiation dose for that patient was reduced by half or increased by factor 2, either one. Now I can do predictive modeling and see how much the quality of those images would have been better or worse, how much uncertainty or error might have been induced by suboptimal imaging, and also follow that in predictive modeling. Now I can know for sure what would have happened if those images for those 1,000 patients were not acquired or suboptimally acquired. Now I can, clearly say for Mr. X, for Mrs. Y, what would have happened with or without imaging, with good quality imaging and bad quality imaging. Would somebody pay for such a project? Again, I feel like it's such a dumb thing to pay for such a project. That's the problem if you haven't done that. Because the benefit's so obvious, nobody wants to pay for something you already know, right? That's why we haven't funded it. And as a result, we have gotten this lopsided idea that calorie is the only measure of quality of the food, and dose is the only measure of quality of imaging. That's the reason.
And so then how do you feel about the approach of quality measures being so based in dose?
I think dose needs to be one of the quality measures, but one of the minor ones that we have to keep track of, but not the only one. In the same way for food, again, I'm using a food analogy. We need to measure the calorie intake of the food. That would be helpful. But we do need to include other measurements of quality. Again, I will mention resolution. I will mention noise. I will measure motion. All of those measurements needs to be done in the context of the indication for which the image was being acquired. So if you do a cardiac exam, then those measurements needs to be made relevant to cardiac imaging, not some generic number out there. It needs to be relevant to that, what I call task-based performance. So the numbers need to lend themselves to the task-based prediction. Because at the end of the day, task is what matters. Nobody cares about resolution or noise of the image. We care about whether I can see the abnormality if present and can I adequately quantify it and characterize it so to know what to do with the patient. I think, again, making sure the benefit is not compromised is something that has not been on the forefront of people's mind. We have perpetually tried to reduce the dose. And maybe some dose should have been reduced because they were too high. But at the same time, if we have that as the only measurement, we might compromise the patient care. That's what I'm worried about. And all of us should be worried about.
And so we are getting close to the end of time. Is there anything you want to touch on or address before we sign off?
One thing I just want to, again, on the benefit side of imaging, early on we talked about, how do we know the imaging provides benefit, right? I use the analogy of exploratory surgery, not analogy, the practice of exploratory surgery. And I just also want to highlight a couple of, landmark studies, one that was related to breast cancer detection through mammography, and the other one is lung cancer screening. Both of those are now a standard of practice. I recently participated in a medical conference in Caribbean region, and they were talking about how the benefits of mammography has not manifested itself in those Caribbean countries. Here in the US, since the screening mammography became the standard of practice in this country, there have been a dramatic reduction of breast cancer mortality in the US. Dramatic. So in fact, people argue that the reduction is primarily due to the mammography screening practice. So there is no doubt that the imaging that we are doing in breast care has significantly reduced the mortality of breast cancer. And the quality that those images produce, and we measure the quality of mammographic exams like a hawk. The quality is really, really high, has really made a difference. In the Caribbean countries, they're also doing mammography, but because the quality is not as closely managed, they have not seen the benefit. So I provide you this example because demonstrate not only that imaging matters, but also quality of those images matters as well. Now, you could ask me the question, if you're fearful of the radiation dose, you can say, wait a second, Dr. Samei, we are exposing all these patients. What about that dose? Are we causing breast cancer? Can you tell me about that? So I will tell you the mortality has decreased in the US. But, from 1,000 women who get screening mammograms, do you know how many cancer we find in them?
No.
Three. 3 out of 1,000. So you could ask me the question, how about the other 997 people that got exposed? In fact, they get exposed every year, right? What about the radiation dose? So this is a demonstration that even though there is a radiation dose, for a vast majority of these patients, we should not call them patients because they're not patients yet, they're people. The majority of these women, there is no direct benefit. There is a direct evidence that the benefits significantly outweighs the risk associated with that hypothetical cancer induction that we're talking about. I can give you more. I mean, the lung cancer screening trial is exactly the same scenario. There is no question that the benefit of imaging significantly outweighs the radiation risk. When we talk about benefit versus risk, we are misrepresenting, we are assuming there are two apples that we're comparing against each other. They are not comparable. One is in the order of pennies, the other one is the order of thousands of dollars we are comparing with against each other. It's not fair. It's not fair. Yes, we need to reduce the pennies. We need to manage the pennies, but that's not the only attribute. People do not come to hospital to get dosed. They come to the hospital to get imaged. So if something worth measuring is the quality of those images.
Dr. Samei, thank you once again so much for joining us here on Frame by Frame Rethink Imaging. It is always a joy to have you here, and I can't wait until you're back again.
Thank you. Thank you for honoring me with these conversations, and thank you for listening to me. Hopefully that would be edifying to your listeners as well.
Absolutely. Frame by Frame Rethink Imaging is brought to you by Immunologics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Immunologics is rethinking imaging in healthcare, visit Immunologics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Immunologics, thanks for tuning in.